Just to give you a brief overview of why we're doing this. If I can make this work. Just point this way, Nick. Over the years as I've been with the League, I've listened to a number of issues that we have to deal with that they're typical city administrative type positions, issues, transportation funding, liability type issues, tort reform. Healthcare has never really been on the forefront of our radar. But as you start over the last 10 years or so, you can see not just with, well, probably a little longer than 10 years, about 16 years ago, I would say, I started paying attention to it. And the reason I did is Tom Hardy had served when he was the city manager of Bountiful, he served on the state retirement board and dealt with all the retirement and benefit issues. And you can see over the last number of years, the blue line here, or turquoise, whatever that line is the healthcare costs for the United States. Everything else, all the various other countries, and primarily in Europe and Asia, is right in that conglomeration. So as you look at this line, you go, well, how is it that, and why is that such a big deal for local government? So as I listened to Tom and then got engaged with Senator Lillenquist on his retirement issues, and you started to see the liability problems that communities were going to have. So we started talking about, just internally, what were we going to do? What's the impact on local government? How does it affect your budgets and so forth? Because for the most part, you need money to run your cities. Money's a big deal. Where are you getting it from? How are you going to get it? And more importantly, how, from an efficiency standpoint, how can you maximize the dollars that you have to be able to provide the services that your citizens want? So then, about 1999, I believe, the Affordable Care Act comes along and throws things into more chaos than what we're typically have been dealing with. So as we would discuss this internally, we started going, okay, where are people at? So as been pointed out to me, there's a lot of people who are very comfortable with where they're at. They have a good sense and they have a sense of where they're at, where they're going, how they're going to get there. They have a number of highly qualified individuals in the city who are capable of dealing with these kinds of issues. Or you could be, you've got a good system, you're in place, you feel good about things, you're helping drive down your costs, and you feel like you're in compliance. Or, thirdly, you really are, be careful not to use this term, but you're scared. And it's an uncomfortable setting. You don't know where you're going. You don't know where things are going. I mean, 2 weeks ago, I think it was, and the Praxis folks can talk about how the smaller businesses, and that's another piece that's interesting to think about, is how local governments are perceived as a business. And so you have to start complying with this just like everyone else. And so a couple of weeks ago, you had a delay in small businesses, 15 to what, Tom? Do you remember?
50 to 99.
No, that was yesterday, I think, when they came out with a delay. There's been a couple of delays the last couple of weeks where its delayed effective date is next year. So you have a constant state of confusion and turmoil. So again, as an organization, we went, okay, what are we going to do? And you ask yourself, who's going to help us with this? Most situations, we're partners with the state or federal government. And we go to the state and we say, okay, we have a big issue that we're dealing with this year on transportation funding. And we're trying to partner with the state. But you start looking at all the various issues that they have to deal with, whether it's the healthcare reform that they're dealing with, transportation funding, education is their dominant discussion. Whether we like it or not, and Senator Lillenquist can address this, they take care of their priorities first. And we're last on whatever it is that they're looking at. We've created a wonderful partnership, so they don't do a lot of things to hurt us, but they're also not doing a lot of things to help us. So what do we expect from them? There's not going to be a lot of help coming their way. I spent a couple hours last night talking with the Speaker of the House and going over a variety of issues. And, you know, transportation funding, some of the concerns that you have, you know, it's on their list, but I can assure you that's not overwhelmingly on the minds of citizens out there. So it's not realistic for us to be able to expect people to help us. So what have some communities done? I was talking with Mayor Seguini and Mayor Piccolo a couple of weeks ago, and a lot of you have hired outside consultants to come in and help you with your benefits analysis. And there's been some insightful ways in which you learn how to do some things. Kind of a best practices act. I'm very comfortable in knowing that you guys share ideas with each other. That's what we do. That's one of the benefits of participating in the league. So we again asked ourselves, what is it that we can do? Recognizing again that there are those who are comfortable with where they're at. They don't need any help. Some are feeling like we're going in a good direction, and then there's a significant number that are saying we need some help and some direction. So the league over the years has done a number of things and part of what our mission is to be able to help you, not just from the obvious things of training and legislative representation, whether it's on a federal or state level, is to be able to provide unique, personal, very meaningful consultation with you. And we've done it in the areas with Dave Church. We have, particularly for smaller communities, we have a general counsel who's available to you. We have Meg Ryan we brought on about 10 years ago that provides land use expertise for you. Susan Wood, you've seen a massive change in how the media interfaces with us as communities, and they're really not telling our stories anymore. There used to be a day when you had a city report or a local reporter sitting in your city hall. If there's one or two in Salt Lake County, I would be surprised. I mean, most of them don't. Dan's a volunteer columnist for the Desert News and writes on a variety of topics, but that's how they do things now. So we sat down and went, okay, what more can we be doing to help tell your story? So we hired Susan about 2-3 years ago. So this is something that I believe you expect from us. We talk about with the board where we're going, why we do the things we do, and healthcare is no different. Whether it's Dave Church in legal, Meg, Susan, or what we do for you on the Hill, it's no different than sitting down, recognizing there's a problem, and getting a set of experts together and talking about, okay, what are the services that we can provide for you as a league? And the main thing I want to emphasize with this is we provide these options for you, as that's just simply what they are. They're options. If you're comfortable with where you're at, that's not a problem. If you don't want to participate, that's not a problem. It's simply putting together some ideas, bringing together people who have a level of expertise that I think are second to none in being able to help you look at a problem that's going to grow exponentially in your community as you manage them. The Praxis Group and Tom and Mayor Joe, we got together, or we've been having these discussions for well over a year. And when Tom retired, went on a service mission for his church, came back, and I was trying to figure out, well, who knows this stuff in local government better than anyone I know? And I called Tom up one day and said, Tom, you know, here's where we've talked about this over the years. You know, what do you think? I've had some folks approach me who have gone to other agencies throughout the state who didn't really express an interest in this. And I said, would you be willing on a voluntary basis, because I'm good at twisting people's arms to contribute their time and talents, and, you know, at the ripe compensation of probably a few Diet Cokes. And Tom was more than willing. And I wanted to take advantage of Tom's 16 plus years of representing us on the state retirement board, as well as his 30 plus years as the preeminent city manager in the state. So Tom and I sat down with Senator Lillenquist, who and I had been talking about this for a while. And then Mayor Johnson decided not to run for re-election, and that's what he does professionally. So we put together a team of acquaintances and friends of mine who do this. And we said, okay, what types of things are communities in need of? and what kind of expertise can we provide them. So then that's where the Praxis group comes in, and we sat down with them, and they were introduced to us by Senator Lillianquist, sorry, Dan. And we started looking at ideas of how can we help you. And so this is the culmination of about a year's worth of ideas and meetings and vacillating back and forth, or what are the best ways that we can offer you services that you choose, not for us to impose on you, but that you may choose to say, hey, I want to participate in this. And so today is really the beginning of, I think, a wonderful partnership that we have with our team. And I want to emphasize this because a couple of folks have asked me. This is something that the league's doing, initiating, but with Tom and Joe's and Dan's generous time. It's not something that they're getting paid for. There's been no league funds that have been expended to do this. This is more of an effort to, as I keep saying, to be able to try and help provide services to you. So we'll start with Tom. Tom's going to kind of carry the day and MC the presentations with the various folks, introduce you to them. And please, this is not a lecture. This is a question and answer. If you have questions at any time, please stop, ask questions. It's intended to be very interactive with us. So thank you for your time, your attendance. I know a lot of you have traveled a long way, so thank you for being here.
Ken, thank you. We have some wonderful people here that are going to help you get hopefully some comfort in what needs to be done for your city with regard to healthcare today. We're going to start out with Dave Hansen from PEHP, who is the General Counsel, and Rachel Ryman, the Director of Compliance for Select Health, to talk a little bit about the Affordable Care Act. This is a moving target. If you can imagine in the Olympics, the biathlon, where the skiers ski very hard and then they get down on their hands and knees or in the standing position and shoot. And they shoot at a target. Can you imagine getting down on your hands and knees and looking through and the target is moving? Well, that's what the Affordable Care Act is, but we have wise people that will hopefully help you understand and sort out for your city what you need to do in terms of compliance and in terms of understanding what the Affordable Care Act is or isn't. They have given me a warranty it will be informative, relevant, and entertaining. So Dave and Rachel, the time is yours.
I'm Dave Hansen. I am General Counsel for PEHP. I also work on the retirement side, so if Senator Lillianquist hasn't answered any questions, I'll be sure to defer all my questions to him about that kind of stuff. So however you want to do that. I have worked there for 16 years now, and I've been General Counsel for the past 10 years with PEHP. I have to give my disclaimer up front, which is that I'm not your legal counsel. Happy to defer to Dave Church for all your legal issues. And unfortunately, lawyers love to give disclaimers. My disclaimer is, on the Affordable Care Act in particular, you really need to talk to your own legal counsel about how to best implement these things for yourselves, for your cities, and how that all works. I wish that I could give you legal advice and answer all your questions, but the liability insurers like to say, no, don't do anything like that. So I'm here to try and give you information about how the Affordable Care Act works and about how it might work for small cities in Utah, and then we can go from there. So the Affordable Care Act, in all its wisdom, does a couple of things. At PEHP, we like to call some of our group the A-team, the actuaries, accountants, attorneys, and administration. So if you're part of the A-team, it's really the cool thing. And as we watch the A-team, you know, that one of their signature lines is, I love it when a plan comes together. And that's the Affordable Care Act in a nutshell, isn't it? I love it when a plan comes together in all its glory. So the Affordable Care Act really tries to do one thing, and that is to try and decrease the amount of uninsured people in the country. Now there's some ancillary things that it does across the way, but it really is trying to have one goal, and that's to solve the uninsured problem. And it does that in 4 or so ways. Let's see. The first one it does is that it imposes an individual mandate on people. So everybody's going to have to show this year that they have coverage. Or you have to pay a tax penalty. The second way is that it expands Medicaid. The third thing that it does is that it requires the employers to have coverage in trying to help those out and trying to impose penalties on employers. And it reforms the insurance market. Has the creation of these marketplaces and a host of all new regulations on insurers across the board and trying to make health insurance better or more affordable, as they would like to call it. So beginning this year, the Mayans were only a year off. The world was going to end in December 2012, didn't quite make it. But the individual mandate takes effect this year. It shows that everybody has to have minimum essential coverage. We'll talk a little bit about that, or you have to pay an additional tax. So a year and a half ago or so, we had the Supreme Court case on the Affordable Care Act, and it challenged the individual mandate. And the court said 4 important things. And I think that they're important to go through because it informs sort of how we're going to look at federal reform going forward. The first is that the court had standing to hear the case because the individual mandate was not a tax. And the second thing they said, which is outstanding, was that the individual mandate is constitutional because it is a tax. So if that seems somewhat contradictory, you're not alone in that. There's some inherent problems with saying both of those things at the same time. The third thing that I think is important is that Medicaid expansion is a coercion on the states. And so every state could choose whether to expand Medicaid or not. And you've heard a lot about it in the news, a little bit about whether Utah is going to expand, and every state gets to decide. One of the interesting parts is the dynamics between the executive branch, the governor, and the legislative branch in how that gets done. The federal government has said the governor gets to decide. He's the sole person. We're going to look to him or her to make the decision on Medicaid expansion, and we're not going to look to anybody else. The legislature in Utah has said, that's all fine and good, but where are you going to get the money if we don't put up our own money? And so if we don't pass a bill that says we're going to expand Medicaid, you can say anything you want and it doesn't make any difference. So there's this little dynamic playing out between the governor and the legislature about how that's going to work. The other part that the Supreme Court case said is that the Medicaid provision can be severed from the rest of the bill. In other words, the rest of the bill is constitutional and can go into effect except for the Medicaid provision that is going forward. So why should you care about Medicaid expansion? It doesn't really affect you. The reason is the costs. And the state, if Medicaid expands, or even if they don't do the optional expansion, is going to have to spend an enormous amount of money just to stay level as far as Medicaid goes. And if Medicaid doesn't expand, you're still going to have this pocket of uninsured people that live in your cities, that live in your towns, that are going to be without coverage, without health care coverage somewhere along the way. And so you need to really be worried about these people that live in your cities, about what they're going to do, either for health coverage, or if they expand, what are you going to do for all the other services that you possibly can provide. So let me give you an idea of what the costs are. The costs gradually shift back to the state as we go along, and the first couple of years the feds pay everything. So here's the state did a study last year to look at what the costs would be, and you can see that the costs are significant. So there's a mandatory expansion piece for Medicaid, and the state has to do that regardless. So there's no expansion. Even with no expansion, the state has to add 60,000 new Utah enrollees this next year. In the first year, they estimate that'll cost $7 million, approximately. Over 10 years, because the feds gradually shift that cost back to the state, it will cost $220 million over 10 years. If the state determines to expand Medicaid, that will add another 60+ thousand enrollees to Medicaid, excuse me. the state saves $11 million the first year. So if they expanded today and said, okay, we're going to expand, we're going to take the federal money's there, it's $11 million, and we're giving that up if we don't expand. It's a loss to the state. However, when they shift the cost back to the state over 10 years, it will cost the state over 10 years $378 million. So that's $378 million that won't go to education. It won't go to roads. It won't go to anything else that the state pays for. It will go to the Medicaid program. Now, the state has also looked at some partial expansion options, and I sort of lumped all those into one. A partial expansion would be that we don't take the federal money, but we still extend coverage to some level of these people that might be uninsured. And that obviously costs the most because we don't get the federal money, and the state actually has to pay more out of its own pocket to make that work. So those look like great options, don't they? Lots of fun for the state to try and figure out which of the worst ones. So if you really take out the $220 million, we're really talking about an extra $150 million the state's going to look at if they expand Medicaid over 10 years. And of course, those costs continue to go up over time, not down. The other big thing that's going to affect you is the employer mandate. And I know you've heard a lot about this already, and so I don't know that I'll spend a lot of time about it, but here's what the statute says specifically. It's in the Internal Revenue Code, section 4980H, that large employers must offer affordable minimum health coverage to all their full-time employees, or they have to pay a penalty. So, as you know, large employers means those that are more than 50 employees during a year. So just by a show of hands, how many have cities with more than 50 employees that are employed? And how many have less than 50? So there's a few, maybe 2/3 have more than 50 and 1/3 have less. So those with less than 50, you're great on this. You don't have to worry about it for 1 minute. There's no penalties attached. You can go ahead and do whatever the heck you want with health insurance and no one's going to come after you under the ACA. Those with more than 50, you have to worry a little bit about this and how it's going to work. I think on my previous slide it showed that it had been delayed until 2015. That's true. You may have seen yesterday on the news there was another delay. So I have not seen the notice yet because it's so new. They announced it yesterday. But they said that for employers with between 50 and 99 employees, they are delaying it an additional year. So this penalty will not go into effect if you have between 50 and 99 full-time employees until 2016. And there's an additional delay that we'll talk about here in a minute. So you have this formula for figuring out whether you have full-time employees if you're on the edge, and we won't go through that right now. So you also have to offer minimum essential coverage. And in short, if you offer any coverage at all, you probably meet this minimum essential coverage standard. It has to meet the bronze level plan, but most plans are going to meet the bronze level plans. If you have any plan with PEHP, you'll meet this minimum essential coverage standard. Full-time employees mean 30 plus hours a week. And you've heard a little bit more about this perhaps in the news in the last little while about whether this is going to cause more people to either terminate their employment or people will go more part-time than full-time, and whether this is going to have an effect on employment patterns or whether it's going to be underemployed. And I think that's all possible. But the full-time employee definition is 30 more hours a week, and that will be significant for folks. The second bullet there talks about you have to offer coverage to 95% of your full-time employees. Part of the delay yesterday said that for 2015, when this mandate goes into effect, even employers with more than 100 employees only have to offer coverage to 70% of their full-time employees rather than 95%. My guess is that if you're offering health insurance to your employees right now, more than 70% of your full-time employees will be covered. It basically means that there will almost be no penalty for 2015 for people that are compliant, unless you just offer no coverage at all to your employees. Almost every single employer is going to meet this standard going forward. And I would imagine that cities, especially if you're offering coverage at all, if you're over 100, you'll meet the standard for 2015. And then in 2016, it will bump back up to the 95% mark. The 95% gives you some fudge room. So if you miss an employee for some reason, if there's some problem and you suddenly you have a full-time employee that for whatever reason slipped through the cracks and didn't get on your plan, you will be fine. There's going to be no penalty that attaches if it's one person. If it goes more than 5% of your employees, then you'll have to worry about the penalty going forward. There's a standard for how you determine whether someone's a full-time employee or not, and I'm happy to answer questions about that, but I'm not going to spend a whole lot of time about that right now. Okay, how much is the penalty? If you offer no coverage at all, it's $2,000 for each employee. Again, these won't kick in until next year or the year after, depending on what size of city you are. If you provide unaffordable coverage to, say, one of your employees, then it will be $3,000 for that employee. If it's more than 9.5% of an employee's income, if the premiums they pay are more than 9.5% of their income, and they've done ways to lower this in addition as well. They've said that you only have to look at the employee's income, and you only have to look at the lowest cost single plan. So it's not every plan that's offered by an employer. It's only the lowest cost single plan. We've taken a look at that for PEHP plans. Most of the plans actually get very close to zero cost. So they have to actually, unless the employee is paying huge dollars out of their own pocket, it's going to be very difficult for any employee right now to meet this standard. Almost all coverage is going to be deemed affordable under this standard. There's a host of new regulations that go along with this, and most of you have seen these before, and they're already in place. We won't go through a lot of them. The biggest one there I'll maybe highlight is preventative care being paid at 100%. That has significant cost on the insurance side. It's estimated about 2% of costs for paying for preventative care. It's all a great idea, and people think that will save money down the road. There's just not a whole lot of evidence of that just yet, and that's a hope at this point more than an actuality. But that has increased costs significantly for health care. Other things that have happened, January 1st, the marketplace is open. And there's community rating, which means that everybody gets lumped into one big pool together in these marketplaces. And they give the rating, and everybody hopes that, and prays, and Select Health maybe can talk about this, that their rates are going to be able to cover what the costs are going to be going forward. And they look at how that works. And you can look and see what the prices are going to be on healthcare.gov for the various different plans based on the metal level. If you're under 50 years old in Salt Lake County, the costs are between $200 and $600 a month roughly. And if you're over 50, they're a little bit higher. And as they go forward. There's a reinsurance pool that's going to try and protect the insurance companies going forward for the first couple of years at least, that everybody will pay into. So if you look nationwide, this is maybe perhaps a little scarier. In the individual market, premiums have gone up 41% in the individual market just in the last year, 41%. I don't know if you've seen gas jump 41% or housing prices jump 41% or what has jumped 41%, but 41% is a huge number. And a lot of it is that these uninsured people sitting on the sidelines are now jumping into the insurance market, and you see this huge jump in costs and how that's going to work. And there are winners and losers in how this works. The winners are women, older workers, and living in the Northeast. If you're there, you probably maybe have a lower cost than maybe you've had before. The losers are men, younger workers, and those living in the South or the West, particularly those in those states that we have there. Utah's 24% increase overall. A 27-year-old gets a 55% increase, while your 64-year-old gets a 2% increase in their cost this year. So if you're older, you get a much smaller bump in the inflation, but if you're younger, it was a significant increase in your costs. We've had about, I believe the updated is 2.5 million or so that have signed up for the exchange, roughly. I'm looking to those exchange experts. And the website seems to be working better for those trying to sign up for the exchange. It's in place. You can still sign up for the individual marketplace until March 15th, and then they'll shut that off for the year, and you won't be able to sign up again until late in the fall for the next year. And so at some point they're going to cut that off and say, okay, no more enrollees. And they're really trying to get a big push to get all the young people into the marketplaces as quickly as possible so that they can get that good risk in there and get the money that they won't have to pay out in benefits. This year, the other big piece that's going to happen is that everyone will have to pay this marketplace reinsurance fee. So in order to backstop the insurers that are participating in the marketplace and all this unexpected or unknown risk that's out there, everyone has to pay into a reinsurance program. And the reinsurance program is designed to raise $25 billion over 3 years. It's trying to keep premiums low at least, or trying to at least smooth the transition into the marketplace. And the cost is $63 per member for this year. So everybody has to pay $63 extra. It's probably built into your premiums. At least for PHP, it's built into their premiums for this year. And that will be paid. And next year, it will change. It will probably go down next year, and will go down even further the year after that in order to raise the $25 billion. We'll let Select Health talk a little bit about the benefit plan restrictions. Other events that happen is that in 2014, they have this rule in the statute that says everyone with more than 200 employees has to automatically enroll everyone in the health insurance. You have to opt out of coverage rather than opting into coverage. They're not quite sure how to do that, and so the federal government said, we're just going to put that on hold indefinitely. And at some point, we'll come back and figure out how to do it, but when that is, no one's quite sure, and we'll figure it out as we go along. Okay, and also in 2014, there's wellness changes. So I'm just curious, how many have a wellness program that they use for their employees? There's a decent number. That can go to 30% of costs of premium rather than 20%. And it's one of the ways that people have used to try and incentivize their employees to be healthier, is to use this wellness program. I've seen a bunch of different models about how a wellness program might work best for employers. But it's been 20% now for 15 or so years since HIPAA passed in Hillary's plan 15 or so years ago, maybe 20 years ago now. And that will go up to, it can go up to 50% if you have a tobacco cessation wellness program that you want to run for your employees. Flex plans also have changes. They've allowed now a small rollover from flex plans of $500 per year if your plan allows it. So if you have a flex plan and you'd like to talk to your administrator about how to do that, you ought to talk to them about whether you want to have the rollover of $500 a year or if you want to continue with the other options that are available. So how do we pay for it all? And this is where it really gets fun, is that there's a host of whole new taxes. So the first one is that there's a new Medicare tax that goes from 0.9% to 3.8% for those earning more than 200,000 single or 250,000 married filing jointly. There's a host of new taxes on producers or manufacturers of medical products, medical device manufacturers, pharmacies, or even health insurance. The last one is the HIT tax. It's estimated to be about a 2% increase for the first year in 2014, and it's expected to go to almost a 4% increase in costs by 2022. About $14 billion a year in health insurance. Just for the record, if you're self-insured, that health insurance tax doesn't apply. So if you're with PHP as a self-insured plan, you don't have to pay that HIT tax. Flexible spending accounts are capped at a certain level, trying to get more income into the federal government. That's another tax revenue maker. They've already changed the rules for HSA penalties have increased if you don't use your HSA for medical expenses. And there's a 2.3% tax on medical devices. That's another one that I've heard in the news several times. And then tanning services. If you go tanning, I know all you are big tanners, I can tell. 10% tax on indoor tanning services. Tom, you have to worry about Tom with the tanning stuff. The last one is the Cadillac tax, and we've got a few years before this kicks in, and dollars to dimes, I'm here to tell you this will probably get delayed, but this is a tax that's going to go into effect in 2018. It's a 40% excise tax on high dollar, high premium plans. And it'll be very interesting to see how this works as we go along, but you can see the limits there on what the premiums have to be for the year in 2018. They have to be under that. If they're over that, you have to pay this 40% excise tax on top of what those premiums are. The early estimates for Utah is that we won't hit those numbers for most of the plans, that we're still going to be well below those numbers. But there are some union plans, and particularly there's a New York governmental plan that have estimated that they will pay $7,000 in taxes per member in 2018. If they don't do anything, if the inflation keeps going the way it's going for medical costs, they'll look at about a $7 billion tax bill just under the Cadillac plan tax. It won't last long if that keeps going the way it is. So we have to be more engaged in what's going on and how we're going to attack the Affordable Care Act and how we're going to respond to that as public entities. Healthcare is not done changing. I want to give my plug that if you can avoid some of the taxes, there's ways you can do that through self-funding, and that's something that you ought to seriously look at. If there's a way that you can become self-funded, I would encourage you to try and look at that option because there are some taxes that are associated with being fully insured. With that, I'm going to turn it over to Rachel, and she's going to take you through some of the benefit changes and how that works, especially from Select Health's perspective.
Good morning. My name is Rachel Ryman. I'm Select Health's Commercial Compliance Manager, and I'm excited to be here today to talk to you a little bit more about healthcare reform. And thank you to Dave for the great overview that he provided. The fact that we started with some technical problems and delays, and we're talking about the Affordable Care Act, is really kind of par for the course, unfortunately. But fortunately, you have great experts here that can help you know what it is you need to know. Yes, it's a moving target, but something that we have our eye on that target even as it's changing on what feels like a daily basis. But today I'm going to talk about just two additional topics, how coverage is changing this year, and then also the help that's available in the market. So first, in terms of coverage, there were already many changes that took effect on plans because of the Affordable Care Act. We're having another technical problem. So some of the changes that already went into effect prior to this year beginning were things you've already experienced. Coverage extending for dependent children through age 26. Dave mentioned preventive care. I mean, the preventive care piece, I would agree with Dave's comments. That has come with a price tag. I mean, if you look even at the women's preventive services that were added just a year or so ago, I mean, birth control, all forms of birth control, sterilization procedures, breastfeeding supplies and support, those are defined as preventive. And for most plans, they have to cover those services at 100%. So that cost, of course, of paying out those services at 100% is passed over to the consumers, to the groups, in terms of a premium increase. Some of the other changes, so of course, no pre-existing for children. Beginning this year, there's no pre-existing for adults. I mean, that's one of the biggest changes in 2014, is coverage is now guaranteed for every individual. There's no longer medical underwriting. Once you come onto a plan, you can't be denied a claim that's a covered benefit simply because you had a pre-existing. So again, huge changes in the market, especially in the individual market, where there are many individuals that prior to 2014 simply couldn't get coverage. They were denied and had to go to high-risk pools, or maybe they were offered a plan, but because of their health conditions, they had a really high, unaffordable rate. All that goes away this year, and you're no longer rated up for your health. It's a community-rated product, so you pay the same regardless of health. But let's talk about some of the benefit changes. One of the biggest benefit changes in the Affordable Care Act is the essential health benefit requirement. Essential health benefits are category benefits. There's 10 categories that have to be covered. Now, they only have to be covered for small employer and individual plans, so that affects some of you here in small employer. Large employer groups, though, don't have to cover essential health benefits, but there's still some requirements that are tied to them, and I'll talk briefly about those. So what are the 10 essential health benefits? Well, the 10 categories The 10 categories you have here, the most surprising when the Act was first released were pediatric dental and vision, generally something a medical plan does not cover. Small employer plans and individual plans now have to cover pediatric dental. And then the other surprise was habilitative services. So if you think about rehabilitation as you lose a skill due to injury or illness and you rehabilitate to relearn that skill, that's something generally covered. Habilitative is you're teaching somebody a skill they didn't previously possess. Generally, that was something insurance companies didn't cover. Habilitative is now a requirement as well. So the federal government never further defined what was essential. When the Act first passed, we had a lot of questions. Well, is this particular service that my son needs essential? Is this going to be a requirement? Well, we were looking to the federal government to really define those 10 categories, and ultimately they put that responsibility on each state. Each state had an option of 10 plans to choose from, and our state did make a choice. They actually chose a PEHP plan. It's a basic plus plan. And so the services that are covered by that plan are considered essential for the state of Utah. To give you an example, though, I was on a call with CMS, and a gentleman from New York said, our benchmark plan, which is really robust in New York, covers gym memberships. So he asked CMS, am I going to have to cover gym memberships on my small employer and individual plans? And I thought, no way, you're not mandating gym memberships. Sure enough, CMS responded and said, if it's in your benchmark plan, it's essential. So if you move to New York, there's some rules with you can substitute some benefits out. But if you're in New York, that gives you an example that, because benchmark plans vary from state to state, it's just another example of how this law kind of changes depending on what type of plan you're eligible for, where you live, and kind of an interesting side note. Now for large employer groups, those of you that are with a large business, you don't have to use Utah's benchmark plan. You can actually choose from any benchmark plan in the nation that's been approved. As we've worked with large employers, though, again, Utah's benchmark plan is the most basic, so many groups are finding it's best to use Utah's benchmark plan so that you're not required to cover additional services beyond what really you're choosing to cover today. And let me explain how this impacts large groups. So the essential health benefit component that impacts a large group is first the annual and lifetime dollar limits. So beginning, it's kind of phased in, but truly this year, you're no longer allowed to have any dollar limits on essential health benefits. You can have day and visit limits, so you can have a 15 visit limit for physical therapy, but you can't have a $20,000 physical therapy limit, as an example. But if services are not essential, so for Utah, as an example, I believe chiropractic services aren't considered essential. So you can certainly cover them, and if you choose to do so, you can have a dollar limit. They're not essential, and we have a lot of groups that's something that they're still doing is maybe adding additional benefits, but having that dollar limit in place to still protect their overall exposure. The cost sharing limits, which a cost sharing limit is really, cost sharing is defined as your deductible, copay, co-insurance. It doesn't include things like balance billed amounts, non-covered services, but beginning this year, there's also a cap on the overall out-of-pocket that a consumer can be charged. And this does apply to large employer groups as well. And this year, that amount's pretty high. It's $6,350 for a single person or $12,700 for a family. So this is just an example. We still have groups that will apply all essential health benefits towards one limit, or you'll still have plans that say, we want to have a separate pharmacy out-of-pocket and a separate medical out-of-pocket. As long as jointly those don't exceed that max, which again is $6,350 for a single person, $12,700 for a family, you are okay. There we go. There is a 1-year exception for groups that have maybe a carve-out benefit. A very common plan design would be maybe you have a separate pharmacy benefits manager, a separate PBM that covers your prescription drug benefits. This first year, if you have a separate carve-out benefit, those limits I just spoke about apply separately to your medical plan and then to your pharmacy plan. But beginning in 2015, even your benefits that you've carved out, if they're considered essential, they're all held to that same maximum. So if this is a situation you'll run into, I'd suggest working with your broker or insurance company so that can be addressed for you next year. In small employer, in addition to that out-of-pocket cap, there's also a deductible cap. And this year, the deductible cap is $2,000 for a single person, $4,000 for a family. So we had a lot of plans that actually had higher deductibles. High deductible health plans are something that are gaining in popularity. So we had groups with a $3,500 single deductible, and we had to lower those amounts this year. And again, this is part of the the Affordable Care Act's way of trying to control those overall costs, to add these caps so that the overall exposure for a consumer, for a patient, a member, is reduced. So let's talk a little bit about the help that's available. I mean, we talked about how there's expanded benefits. In addition to the Affordable Care Act, we also have things like mental health parity, which is greatly expanding mental health benefits in the small employer and individual market. So if you couple the expanded benefits that are available with guarantee issue, guarantee renewability, the fact that plans in small employer and individual are community rated, so you can't, as an insurance company, rate based upon the risk you're taking on. I mean, we had to set our prices for 2014 by May of last year. We're looking by May of this year, we have a deadline to set our community rated products, our prices for all of our small employer and individual business. We have to have it set this May for all of 2015. And you can see what a state of flux the industry is in as we continue to see extensions and delays. I mean, talk about moving target. I joke that our CFO is in the back room with a magic 8-ball just guessing what the premium. I realize that's not what he's really doing, but at this point, I mean, with so many things changing, it's really difficult to accurately set where your prices should be. But of course, we're working hard to do our best there. So considering you have all these expanded benefits and additional exposure, prices are going to go up for many people. But as most of you know, there is help out there for a lot of consumers. So let's talk briefly about those. So first, in the individual market, there are two forms of subsidies, two ways that individuals will be helped. The first is an advanced premium tax credit, and the second is a cost-sharing reduction plan. So with the advanced premium tax credit, in order to be eligible, you do have to purchase coverage through the marketplace. So in Utah, that means going to healthcare.gov to buy your coverage. And yes, it is getting better. The first month, good luck even getting on. I think we had a few people in our office who after several hours made it through, but it's definitely improved. But if you've got a family, a friend, a neighbor who's looking to get individual coverage, they can go to the marketplace and see if they qualify for the subsidy. They have to be a legal citizen. And this next one, they can't get insurance through their work, is a big one. We have a lot of people that have come to us to say, gosh, when I look at the income range, I qualify for a subsidy, and a rather generous subsidy, but because they're offered employer-sponsored coverage, they can't get the subsidy. So simply, it doesn't matter whether they take their employer-sponsored coverage or not. If that coverage is offered to them, and it's affordable and provides minimum value, as Dave spoke about, they're ineligible for a subsidy. Something to keep in mind. They can't be eligible for public programs. If they belong to CHIP, Medicaid, Medicare, that's where they belong. And then their income has to be between 100 and 400% of the federal poverty level. And I'll show you a chart in a moment, but as an example, a family of 4 can make up to $94,000 a year and still get some level of a subsidy. It's a sliding scale, but there's still some help available for them. So this is an example of kind of how the subsidy work. I think the average consumer is going to have no idea. They'll go on to healthcare.gov, get a dollar amount, and wonder how that was computed. Kind of how I feel with most financial things in the federal government these days. But as an example, if you make between 133 and 150% of the federal poverty level, you only have to pay 3 to 4% of your income for your premium. And that's based on not just any plan you pick, it's based on a particular silver plan in the market. So the most that individual would have to pay would be $56. How that would work is if the premium for that silver plan in our market is $256, they have a $200 subsidy. So they can buy that plan and just pay $56, or maybe they say, you know what, I want richer benefits. I don't want a silver, I want a platinum plan, I want a gold plan, I want to go higher. They'll of course pay more for that. But we're also seeing situations where people are buying lower value plans using that subsidy, and they have to pay very little, if anything. So it just really kind of gives them an amount they can shop with when they go on the marketplace. We do have a really easy to use calculator. If you go to selecthealth.org, the consumer can plug in some basic information about their family size, their income, and this will give them a quick and easy answer to, hey, am I eligible for a subsidy? And if so, how much? I tell my friends it's a great place to start, because if you do qualify, or if you don't qualify for a subsidy, it's so much easier to go directly to the insurance company that you want to work with, rather than going through healthcare.gov and dealing with all the technical issues. I'll tell you, 2 weeks ago, we had a couple of consumers who wanted to cancel their policy for whatever reason. They paid for January, they wanted to cancel their coverage in February. So as we reached out to CMS and said, how can they cancel? Because if they go through the marketplace, we as an issuer aren't allowed to cancel them unless it's for non-payment of premium. We called CMS and said, how do we get these guys canceled? Can we transfer them over to you? And they said, we don't have the functionality built yet. I'm not kidding. We had issuers nationwide on the call, and they literally didn't have a way to cancel a consumer who wanted to voluntarily cancel. As I told our sales vice president, he said, best news ever. So once they pick us, they're with Select Health forever? And I said, well, no, they're going to figure that information out. And of course, he was joking, but they're just barely this week now have the functionality to cancel somebody who wants out. So use the tools that are out there before I think you decide to use healthcare.gov would be my suggestion. So in addition to the advanced premium tax credit that helps people pay for their premium, I'll touch briefly on the cost sharing reduction plans. And basically what these do is these are for the really low income earners, those between 100 and 250% of the federal poverty level. In addition to getting help paying for their premium, there's also cost sharing reduction plans they can enroll in, which basically lower the overall out-of-pocket, deductible, copay, the overall cost sharing they should expect to pay. So they otherwise may have bought a plan that has a $1,000 deductible, and some of these deductibles are dropped clear down to $100, and they're subsidized. So the federal government, the additional amount we pay out as an insurance company, is subsidized by the federal government. Again, if people qualify and they're these income levels, these are great plans, very generous benefits that really will help kind of these consumers who are trying to get coverage to either protect their family or to avoid the individual mandate. This is just an example of the income levels. So this is an example of family with a family size of 1 to 5. You can see there's kind of the range. So for example, if you look at a single person making $22,000 a year, the most they pay is $117. And then on the far side, it shows you whether they qualify for a cost sharing reduction plan and that value. But kind of an easy tool our brokers have been using. Dave mentioned in large employer, there's a penalty if you don't have coverage, right? If you don't provide coverage to what was 95% of your employees, now that's 70% next year. But what about small businesses? We've talked about how there's not a penalty. Well, in small employer, rather than the stick, there's the carrot. For small employer, there is actually a tax credit available. And this is really only available for the smallest of the small groups. You have to have fewer than 25 employees. Your average wages for your employees has to be less than $50,000. That doesn't include the owner or their family. And then it's a sliding scale, but this tax credit goes all the way up to 50% this year. Really generous tax credit if you qualify. We also have a tool on our website as well that you can go out and an employer can plug in their information to see if they qualify. But just a great program to help those small employers who are looking to provide coverage and are struggling to do so. So in closing, I really more wanted to open up for questions. We do have some great resources. We've got what are called healthcare reform at a glance that take this down topic by topic. One on essential health benefits. If you want to understand, employer penalty, we've got one brief on that. I'm happy to get those to you. In addition to myself, I've also invited Mark Tenney, who's with Intermountain Healthcare, over their benefits. If you've got questions for him from an employer's perspective, they've done a lot to prepare for the new employer mandate. They worked with some consultants and other things that he could speak to. And then I know Dave is here for questions as well. So I don't know if there are questions from the audience, and otherwise we're happy to address those later.
What can we do to move our healthcare along so that we are at the cutting edge and not the back edge? To do that, we've asked Dan Lillenquist, who works as a consultant with Select Health, to talk a little bit about some of the futuristic things that are coming down the pike in the next several years that we can all use and avail ourselves of. So I'd like to turn the time over to Dan.
Great, thank you, Tom. I'm pleased that you all stayed awake during the last part of the meeting. You know, health insurance is so convoluted. It reminds me of and particularly with the 2,700-page bill that we're trying to deal with, and thousands of pages of regulation. It reminds me of a quote by Friedrich Hayek, who's one of my favorite economists, who said the curious task of economics is to demonstrate to men how little they really know about what they imagine they can design. And I feel like as we get into the Obamacare mess, we realize how little actually we did know, or we collectively as a country, as we began this experiment, all the different intricacies and all the different problems, and it certainly has created some problems. And I'm sure we'll work through all of those. What I'm excited to talk about today, though, is there are some good things that are happening, and some really fundamentally good things in the health insurance provider sector of this economy, or this country. Our healthcare system is the largest, most expensive healthcare system in the history of mankind, making up almost $2.5 trillion a year. And essentially, folks, that's been an indication of our tremendous wealth. And the fact that we've been able to spend that much money is, we do things here with healthcare that people only dream about in other countries. And so there's some very, very good things, and I think that's important to keep in mind. But like any industry, as healthcare grows or any other industry grows, it's got to get to the point where it matures. And right now we realize that healthcare is growing too quickly, that we can't afford it. As you as city managers and other city leaders realize that it's just unsustainable the way it's going. But what I'm excited to tell you about is some areas where there's convergence in the marketplace, and really some interesting new things that are actually going to drive better quality at lower costs. And certainly that's going to be disruptive for certain business models. I think it's certainly going to be disruptive for the traditional doctor practice, like my dad's. He was an endocrinologist, and he saw patients every 10 minutes for 40 years, and that model is going to change some, and I think for the better. So there will be disruption in the provider community here, but I think the beneficiary of that will be people who have to pay the price. Now, I want to specifically talk today. I think the last meeting I spoke a little bit about where large healthcare systems like Intermountain Healthcare, and I work for Intermountain Healthcare, but also the University of Utah and IASIS and other people in the state are building integrated systems similar to Intermountain's to really focus on driving down costs and appropriate utilization, actually improving utilization in the most appropriate settings for healthcare. Down the road, you know that just like Medicaid has been moved and Medicare Advantage have been moved to kind of a capitated system, a system that was similar to what we had in the 80s with HMOs, but really now more provider-driven. You're going to see health insurance companies and their associated providers going to market with more competitive rates in the years to come. Select Health, for example, has publicly committed that within the next couple of years, they will be going to market with a price target of CPI plus 1%, which is a whole lot better than what it's been historically. And so you're seeing systems like Intermountain reorient towards a fixed payment model and trying to govern ourselves so that we can provide better value to the community. But that aside, there's another trend, and I think there's really three unstoppable trends that we've recognized at Intermountain that actually will also help drive down costs and improve quality. And they're all consumer driven. Now, one of these is not going to be a surprise to you, the adoption of high deductible health savings accounts along with really consumer driven health plans. We've been through this, but I want to show you some data that has recently come out on these things, if I can get this to work. You see over the last 10 years a substantial adoption of these type of plans, consumer-driven health plans, among large employers. They are becoming more and more common in the marketplace as employers, and we did this at the state a few years ago, as basically the idea is, hey, we are spending a lot of money on healthcare. We've got to have the consumers feel responsible for how they're spending the money. And the best way to do that is to, as we found in the state, as we drove adoption of a high deductible plan at the state through PEHP, we had a 1,500% increase almost overnight. When we started placing the regular health insurance plans on par with the high deductible plans, making the out-of-pocket maximums match each other, but then also funding, when we increased the deductible, we turned right around and funded an HSA to make them equivalent economically. You're seeing actually some employers, you see the adoption of these plans are climbing too. So as they're offered as an option, people are choosing these plans more and more. And some companies, if you look in 2013, 14.5% of all the companies, large employers in the country, are mandating that you participate in these type of plans. And here's really, this clicker is, and here's why. When you have a total replacement with these plans, you see a substantial change in consumer behavior. When somebody now goes to a doctor's office and it's their money out of their HSA, which they get to roll over into retirement if they don't use, they're asking questions like never before. And we're seeing this in our Intermountain facilities. People come in and saying, hey, how much is it going to cost to see the doctor? Those are questions that haven't been asked. We've recently gone through an exercise at Intermountain Healthcare on normalizing all of our imaging costs across the company. We realized over the years we had different schedules all over the place. Well, we had to change those because people started asking, how much does this cost? And because people are asking and are being price sensitive, you can drive a lot of behavior change that can drive down your costs through these types of plans. And you see it right here. I think most excitingly for your employees, over the years, this is the amount of money. It's now up to $5.6 billion and climbing. This is how much money now nationwide are held in high deductible health savings accounts. That people, if they don't use the resources you're putting towards healthcare, are able to save them, to roll them over, and to augment their retirement. And it's a big deal. So there's benefits that can inure to the individual just by introducing. And you can do it in an economically fair way where their out-of-pocket max are the same as other plans. You just give them a choice. And eventually, the people who choose this, it really does benefit them. That's a trend that will continue. In fact, I think this is my personal opinion, I think this trend will be accelerated because of the health insurance marketplaces. And think about it. If you go to the health insurance marketplace and look at a plan, and you see a 90-10 plan with premiums that are this, or a higher deductible plan with a higher co-insurance that the premiums are this, and you know you have a certainty of paying the higher premium or the possibility of paying a higher premium, people are going to choose more and more. They're going to say, look, if out-of-pocket maximums are the same, but I'm not going to take the certainty of a higher price. I'm going to take the lower price, and that's what you're going to see. So I think you'll see additional adoptions of this. I don't want to dwell on this. You've seen this, but really, folks, this works. And if you introduce price sensitivity through your plans to your people and give them a way to capture that value for themselves after the fact through a high deductible or through a health savings account option alongside it, it can drive a lot of good behavior. Now, the next trend I want to talk about, let's see if this works, is a really, really interesting trend. And this has just happened in the last, I would say, 6 months to a year with a couple of major investments by Kleiner Perkins and the Heritage Fund. Because of the adoption of high deductible plans and health savings accounts, there is a lot of downward pressure on price. People are saying, why do I have to go to see a doctor to get my blood pressure medication renewed? He looks at me for 5 minutes and it bugs me and he's just going to give me the same prescription. Why should I have to go in and pay $150? Well, you know what? I work with a group of about 8 people doing strategy for Intermountain. And over the last 6 months, every single one of us had that same complaint. Well, now what you're seeing is the rise of telecare. And let me explain what this is. Traditionally, you would go to see a doctor, and you would sit down face to face, and if you're lucky, you can get an appointment within the next 3-4 months to go in and see them because you have a doctor shortage and all these problems. That's how we used to see doctors. But now, right now, on my phone, there's a company called America Well, and there's dozens of these companies, that I can get on my phone and hit an app and hit a button and teleconference with the doctor within 5 minutes. I can be on the phone, face to face, over my phone with the doctor. The market is moving in a direction because of a variety of factors I'll get to in a second. That Don Berwick, former head of CMS, says by 2017, 8 out of 10 office visits will be done through telemedicine. And it's absolutely remarkable how quickly this is moving. Intermountain's moving this direction, other people are moving this direction. But let me tell you why it's moving. There's a handful of factors that are really driving this. One is increased cost sensitivity. And that is really coming from these high deductible plans with health savings accounts attached to them. People are starting to say, this is my money, what does this cost? I'm responsible. And again, consumer driven. But then you also have groups like CVS and Walgreens and Walmart and others who are really taking the very, very low end of healthcare, that healthcare market. So think about it, when you get a sore throat and you need a strep test, there's a whole bunch of basic levels of care that you don't need to see a highly trained physician to take care of. Well, you know, you're seeing companies out there now like these, like Walgreens and CVS, and they're growing nationwide, who have said, you know what? We are going to start offering nursing services in our Walgreens and CVS's or at Walmart. So when you have a strep throat, you don't run to an urgent care and pay through the nose. You can come here, you can see an advanced practitioner, registered nurse, and they can write a prescription right in the store and take care of your issue. Well, you're seeing people now go to market. And you can go online and find these companies who will give you a set price. Here's how much a strep test costs. Here's how much a physical costs. Here's how much all of these different types of services cost. It really is a unique change. It's really the commoditization of basic care, putting downward pressure on price. The third is we have a doctor shortage. If you go, the news just covered this in Massachusetts. The average wait time is something like 70 days to get in to see a doctor. Because we're not producing the number of doctors we need, we've constrained it. The system says you have to see a doctor to get certain things, or people in their minds think they have to see a doctor, but there's constraints. And then you combine those three factors with the ubiquity of technology, with smartphones and with computers and broadband, where you can actually connect and video conference with people, and then also really kind of the on-demand culture that you're seeing. Now, people expect healthcare now. This is what's driving the adoption of telecare. In the last couple of years, a handful of telecare companies, including Teladoc, MD Live, Ameridoc, and others, have grown from about 500,000 members to about 20 million members nationwide. And what they do, their business model is this. They go to an insurance company or to a large employer and says, you know, pay a per member per month access fee from between 50 cents a month and $2 a month. And then we will provide 24/7 access, and when people call in, they'll pay a $30 to $40 fee, and that's it. And we'll start taking care of them. Well, this has really taken off, and here's what it means for employers. You're seeing a dramatic reduction or a dramatic change in consumer behavior. If you look at this chart, this is from one of those companies, Teladoc is the largest, has the most published information, but this is stuff you're seeing from providers of telecare. You're seeing that people who called in, of 100 people who call in, 9% of them would have gone to an emergency department instead of calling this service. at a massive expense. 33% would have otherwise gone to an urgent care. 1% would have gone to a specialist, and I think that's kind of the outlier. 43% of them would have gone otherwise to a primary care doctor face-to-face, at usually 3 times the cost. And you're seeing a dramatic reduction in utilization and cost. Why? Because of all these factors converging. And so you're going to see the rise of telecare companies. They're already out there. We have companies that have come into the state right now who are servicing members of the people of the state. There's a group out of Texas at Bear Dock who's servicing people at CR England. So you have a trucker who's traveling around out of state. They're sick. They don't know where to go. They call up this service. They get a prescription for the basic stuff they need. And it's really quite remarkable. That will change and continue to grow. And I anticipate that Intermountain Healthcare will be in that space just basically because it's actually a really smart way to lower healthcare costs and drive appropriate utilization. So that is a trend. Yes, Joe?
Dan, on this question, for the cities, then, is this a fee? I mean, can they buy this for their employees? Is it part of the plan?
Yeah, so Joe, good question. You can actually buy this for your employees to reduce your own costs. If you're a large enough employer, they'll do it. I'm not sure what the rates will be. Obviously, the larger employer will get the better deals. But I personally think that this is going to be an offering eventually through our health insurance companies. So think about it. Health insurance companies take in a premium, and then they actually have to pay out the claims, and if there's a way for them to be more competitive and offer this service to drive down inappropriate utilization, a lot of these large insurers, United Healthcare and others nationwide, have invested heavily in these groups, and I anticipate that this will continue. And if you think about it, it is a complete disruption of the traditional market. A doctor, instead of having to have a receptionist and staff and billing and all this other stuff that they have to actually get paid, in this model, an individual calls up, pays $50 or $40 from their health savings account. The doctor doesn't have to do any billing, any worry about that, and can just practice medicine. So this is exceptionally popular with doctors, and it's growing. So Joe, this will flesh itself out. I honestly believe, and this is my opinion, my recommendation for Intermountain is to get into this space, is that you will move up market into diabetes management and other things, long-term disease management over this. Think about it. If you, instead of having to go wait to see a doctor, you have an issue, you have a question, and have this access, you could talk to an RN or a dietitian at any time. And that actually goes hand in hand with the third major trend, and this is a new word. It actually, the spell check didn't catch this, gamification. And I like that word because it's kind of interesting. There's a great book called The Creative Destruction of Medicine by Dr. Eric Topol. And what he says is, the most important medical device of the next 10 years is your cell phone. That's going to be the most important medical device. It's going to be your smartphone. Because what's happening is you're seeing a convergence of technology and healthcare like never before. How many of you saw the other day, my dad's an endocrinologist, I have 3 brothers with diabetes. They've been pricking their finger forever. And it's terrible. And they have to keep track of all their scores, and their glycohemoglobin scores get high, and they have all the kind of long-term complications of diabetes. My dad has been, he was a professor of medicine at Vanderbilt, has done research for years and years for drug companies and device manufacturers trying to find a way to monitor blood sugar continuously. Because people go into insulin shock while driving and die, they'll have all kinds of problems. In the middle of the night, they won't know their blood sugar's low, they have all kinds of issues. Well, Google 3 months ago announced a new technology that they're working on, that they're putting in trials right now, and it's a contact lens with a chip that measures the glucose in your tears and transmits to a phone what your blood sugar is doing. Absolutely incredible what's happening. You will see a convergence as chips become smaller and smaller, a convergence of disease management and technology like never before, focusing on preventative care. Now, there's other things. When I say gamification, let's just skip through. Because of the convergence of technology and healthcare, you're seeing all kinds of new creative integrations to help people manage their health better. The first one, and my favorite one, I bought a Nike Fuel Band. Have you seen these? There's a Fitbit on there as well. Some of you saw me in my legislative days. I was very, very chubby. But I bought one of these things, and and it's fun. It's a game. Basically, it tracks my activity every day. I set goals, and I check this thing out. I hit a button on it, and you can see how many fuel points I've earned, which is a basic measure of activity, and it normalizes for everybody. So I keep track of that, and I think, I've got to hit this. Well, I've lost like 50 pounds. And it's been great for my health. My blood pressure is better. My heart health is better. What is that? My good cholesterol is great. But I don't know if I could have done it without having a tool like this. It's basically a toy. And because of that, the visibility of what's going on with my own health, it's awesome. So you're seeing more and more people do this. It's a great, by the way, part of your health and wellness programs and those type of things. I think Ken Bullock bought every one of the league one of these things. Is that right, Ken? But then you're also seeing some pretty interesting things. I had 2 type 1 diabetic brothers who were 4 years old when they got the disease, who really struggled to manage their disease. Well, now they have apps on phones that teach kids how to monitor their blood sugar. And they're actually tying these things to blood sugar, to your testing equipment for blood sugar, that you can basically make a game of keeping yourself healthy. And then finally, I met the owner of this company, patientslikeme.com. You're seeing a massive amount of social media activity with respect to healthcare as people are finding communities and with rare diseases and manage them together. It's been a quite remarkable thing as now healthcare companies are finding these communities and tailoring treatments specifically to them. So folks, there's a lot going on in healthcare. What does this all mean? Look, consumer-driven care is here to stay. And I think personally what it will do is it will finally flatten out the incredible cost run-up we've seen with healthcare and start to lower costs. Just like cell phone prices have dropped, just like computer prices have dropped, the convergence of healthcare and technology, and particularly putting the consumers in the driver's seat, will actually make things better going forward. So there is hope on the horizon.
I'd like to turn some time now over to Crawford Advisors.
Good morning. I was 2 years in the insurance business when Gerald Ford signed the Employee Retirement Income Security Act. And it was a result of the Packard Motor Company and the Studebaker Motor Company merging and not being able to survive. There were thousands of people who lost benefits, lost their retirement plans, lost everything. And that happened in 1963. So 10 years later, Ford signed this huge act called ERISA. And what it was, the main purpose was to protect people, to protect employees from employers, to force employers to disclose information, what was going on with the plan, just to protect people. It created the Pension Benefit Guaranty Corporation, which took care of all the Eastern Airlines employees when they lost their pension. It created the individual retirement account. It created several things, but the most sweeping thing that it allowed was it allowed an employer to provide employee benefits without using an insurance company. McCarran-Ferguson regulates, McCarran-Ferguson gave the states the authority to regulate insurance companies. So in Utah here, or in any other state, the insurance departments regulate insurance companies. The federal government over time has has passed laws since ERISA that require employers to do certain things with self-insured or self-funded health plans. And those laws have changed greatly over the years. Much like the state mandates for each state have changed greatly. So today we have 4 different market segments. We have the individual market segment. We have the small group market segment, which I guess can be broken down to employers that have up to 25 employees. Then we have another market segment from 25 to 50. Then we have another market segment on top of that, which is 50 to 100. And then we have over 100. So what do? I can't stand up here and address all 4 or 5 of those marketplaces. So what I'm going to talk about today is I'm not going to talk about the individual markets. I'm not going to talk about the under 25 employee markets. I'm going to touch a little bit on the over 50 markets and the larger markets on some of the things that are out of the box. Some things that you're not going to hear from insurance companies because they have to comply with the state law. I think Dan's presentation was absolutely fantastic. And I talk about those things all the time because they are going to change the world. The fact of the matter is we change very slowly. And we have to appeal to a broad sense of the market. By that I mean people. So we can't ask me, a 57-year-old guy, to read the Wall Street Journal on a smartphone. I'd rather hold the paper. But my son is using his smartphone to read the Wall Street Journal. So we have to appeal to a whole broad range of people. So with that being said, I want to give you some things to think about in my presentation today. I want to thank the League, and I want to thank Praxis, and I want to thank all of you for being here. And I hope that the next few slides are not going to bore you. My group, we have to leave, so what I'm going to suggest that you do, if you have questions about any of the things that I'm going to talk about today, which some might be a little redundant, if you can just get to Praxis or to the League with your questions, what we will do is we will publish an FAQ online that everybody here can access, and you can benefit from everybody else's questions to the extent that you wish. We're going to talk today about who we are and what we do. I've got a slide in here on differentiating spending accounts, but I don't want to go through that. We've already done that. I want to talk a little bit about alternative healthcare delivery systems and where they could come into play, where they could help you, larger employers. I'm going to talk about some consumer-driven tools very briefly. Dan did a great job. I don't want to be redundant there. I'll just tell you 2 or 3 of the ones that we use. I'm going to talk to you about high deductible health plans using an HRA reimbursement scheme. This is going to be in the world of self-funding, and it can be in the world in smaller cases of fully insured plans. Since the Affordable Care Act has mandated that insurance companies provide coverage to people without evidence of insurability and without pre-existing conditions limitations, it's opened up an opportunity for employers who have retirees under age 65 to perhaps give them an option to the existing employer retirement health care plan. So I'm going to talk to you a little bit about that. AGRIP plans. These are plans that as you all know, most of you know, the federal government subsidized pharmacy plans for employers who provide coverage. Then we're going to talk about skinny or MEC plans that comply with the Affordable Care Act. These are plans that employers can use to provide coverage for employees to meet the minimum essential benefits that you will be surprised on how affordable they actually are. So a little bit about us. We've been in the benefits business since 1977, and our business model is a little bit different than most of our competition in that we do everything internally. We have built a platform where we provide consulting services. We maintain repositories with data, which are going to become very, very important when you try and comply with the Affordable Care Act going forward. Structuring plans, payroll deduction methodologies, consumer-driven approaches. We did our first internet enrollment in 1995 for Payne Webber. So we're very on the cutting edge of that. We also maintain a medical claims data warehouse that we use to predict future costs by stop-loss insurance.
defend our position, if you might, with our employees when we're making plan design changes or changing payroll deductions. We do administration internally for health administration accounts, health savings accounts, other types of transit accounts. We have a financial resource center that's staffed with actuaries and financial people that do modeling that's necessary to make decisions in this environment. We have a call center. We have a publishing area that's staffed with graphic artists where we do communication pieces. In this world, when you make a change, it's very important that you communicate it. And we have 3 mediums of communication. The hard copy guy like me that likes to read the Wall Street Journal, somebody in the middle that is, playing with a Kindle or an iPad, and these smartphone kids that just do everything on their smartphone. We have a compliance area. We've got an ERISA attorney on staff that helps us with such things as your question about how do you discriminate in a plan? What do you do with these part-time people? What rules are you subject to? Is it a pre-tax plan? Is it a self-insured plan? There's all different kinds of rules that you need to be aware of when you structure these plans. So that's what we do. So let's get into some interesting stuff here. Okay, alternative healthcare delivery approaches. These are some products that you may or may not be aware of. Insurance companies of late, prior to the Affordable Care Act, were kind of delving into this area. Back in the day, in the late 70s, Blue Cross and Blue Shield dominated the market. They provided coverage for so many days in the hospital. Blue Shield had its genesis in 1933 in Seattle, Washington, where it provided a way to pay physicians. So they created what we call a surgical schedule, and they assigned certain points to that surgical schedule, and the insurance companies assigned so many dollars to those points. So that became known as a surgical schedule. So you had a hospital plan and a surgical schedule, and then you had a diagnostic benefit. We used to call it Diagnostic 4. And then we had other things. These are all things labor tried to not negotiate out of their contracts. So that's what you had. Then we had the advent of major medical that came on top of that. So some of these plans that just kind of came into being over the past few years emulated what we were doing in the 70s and 80s. And now they're called limited benefit plans, gap plans, critical illness plans. What they do is they indemnify employees and dependents for different things. So they help employers who want to use that high deductible approach. I believe a high deductible approach works best, really only works when you use it as a total replacement. To have it as an option and compete against the other plans, it generally doesn't work. These policies pay a specified dollar amount for outpatient procedures. They pay a specified dollar amount for inpatient procedures. They could pay as much as $1,000 a day for inpatient hospital care for 30 days, or as much as $2,000 or $3,000 a day for inpatient care. When coupling that plan with a high deductible plan, it works great. It really does work great. The Affordable Care Act requires that an employer offer coverage as an essential level of benefits to employees and their children. It doesn't require that you offer that coverage to spouses. Anybody how many people are self-funded here? Okay, well, you know that in most cases half of your claims are your spouses. So if you were to find another way to deal with that group of people, it might be a very financially viable alternative. Critical illness benefits are another benefit that these are policies that pay a lump sum payment for as many as 12 critical illnesses: cancer, heart attack, stroke, the loss of a limb. These payments are paid in a lump sum payment. There are 2 approaches that you can use. There's a guaranteed issue approach where the employer can provide the coverage. You can provide voluntary benefits where the employees can pay for it. You can't really include it in a pre-tax plan because the benefit will be taxable when it's paid. But these are things that you can use, again, to augment those high deductible plans to show your employees that there is alternatives other than to just reach into their pocket or reach into their HSA and pull money out. These are the 2. There's a simplified issue and a fully underwritten issue. Benefits can be as high as $500,000. There are about 35 or 40 insurance companies that currently offer these benefits. They're all different. They're filed products. Depending upon what state you're in, depends on how they're done. There are group products that are issued that are on a group chassis, and whatever insurance company, wherever you are, and the policies issued, that state will regulate the policies. Accident plans, same type of thing. Pay a lump sum benefit in the event of an accident. Again, these are all benefits that can be used to augment these high deductible offerings, and they're very, very reasonably priced. These are gap programs. Some of the statistics at the top of the slide show how high deductibles and out-of-pocket expenses are on a typical high deductible HSA plan. These plans can be purchased in increments of $500 up to $10,000, and they'll pay in the event of a claim, in hospital claim, out of hospital claim. There are different schedule amounts. And the return, if you look at somebody who's got a $2,000 deductible, who says, okay, I'm going to try and fund for some of that because I want to lower my premium contributions. If you look at the cost to insure that as compared to funding it in an FSA or an HSA, it may be a more viable alternative. So you can take those payroll deductions and move them towards your 401k or some other vehicle. But they work very, very well, and there's several of them. There's several formats that they use. This is a sample pricing that you could take a look at. This is a benefit here of a $500 payment, and this is a $3,500 payment. And I've scheduled the rates here for people under 55, people over 55 to 59, and people over age 60. So if I've got a $3,500 exposure, and I have a high deductible health plan, and I buy a gap product, the monthly premium for that gap product is $35 a month, considerably less than the amount of money that I would have to put aside to fund that exposure. So when you couple these offerings together, for the accident, for the critical illness, it's going to be where we are all going to be, because when you go to Canada, there are 10 provinces in Canada, and there are high deductible plans in Canada, and they've had the whole national health thing for years. These are the products that employers in Canada are buying to keep their employees whole. Here's a small group case study. The principle here is taking a typical deductible, like a $500 deductible, increasing the deductible to $3,500, and buying a gap product that will reimburse the employee for that $3,500. This 66 life case can save as much as, what's the number down there, $80,000 a year? Works great. It's an insured product, and most likely the insurance company's making money, right? So here's a large group case study. This is a large group in the central part of the United States that was self-funded. They had 3 different offerings, 3 different payroll deduction schemes by tier, and the payroll deductions were by income. So we kind of leveled the playing field. People under $25,000 paid less than somebody more than $75,000. And what they were upset about was the fluctuation in the claims. You know, one month it might be $600,000, the next month it might be $1.8 million. And it was frustrating them. They were looking for a solution. So we said, well, maybe the way to go is to give up this whole self-insured status and go back to being fully insured with a high deductible health plan, in this case a $5,000 deductible health plan, and then buy insurance if you're scared to cover that $5,000 gap. So we did that, and it produced a savings of about $900,000 because we could release the incurred but not reported claim liability plus the premium savings. Now we know that inside this gap product there's lots of money to be made for an insurance company, lots of money. But what it does is it gives you an employer peace of mind. If we were to self-fund that gap exposure and do the same thing, the savings would be much, much more than that. Typically, 3% of your members are 50% of your claims. Not too much you can do about that. 80% of your members incur less than $2,500 in claims, and about 60 incur less than $1,000. So we as a group collectively make claims decisions based on, well, if we increase the deductible by $200, our premium costs go down by 2%. It's not necessarily how it works. So these are some other consumer-driven tools. I'll just, they're here. Pocket Doc, same thing on your cell phone, look at your docs. One of our favorites is down here in the left-hand corner. It's a company called Castlight. It does the same thing that Dan was talking about, only it's on steroids. It rates the doctors based on their outcomes. It rates the doctors based on how they communicate with patients. It rates the doctors based on their cost, geographical location. It's a great tool, same type of thing. You pay X number of dollars per month and you introduce it to your employees and they do it and they have outrageous outcomes where they save money. High deductible health plans using an HRA scheme. This is a novelty. We've been doing this for a few years where we do basically the same thing I spoke about earlier. Use that high deductible across the board with everybody and employ different schemes underneath that $5,000 deductible to reimburse your employees, charging them more for the highest reimbursement and less for the lowest reimbursement. We've seen it work in many cases over 4 or 5 years. This is a company here, a smaller company that has, if my memory serves me, about 70 employees. We took this company from a typical plan where they had a low deductible PPO offering, and we moved them to a high $5,000 deductible offering, employed 3 different scenarios for the employees to pick. They could pick whatever they wanted. Payroll deductions were whatever they wanted to pay. If they wanted to pay a lot of money to get a lot back, or a medium amount of money to get a medium amount back, or pay little to have a lot of exposure, we let them do it. But over a 4-year period of time, we've saved this small 60-some life employer $1.3 million. And those statistics that I mentioned earlier are pretty right on. The over 65 and under 65 retiree solutions after the Affordable Care Act. When the Revenue Act in 1978 was passed and created the 401k plan, we were all in trouble. My parents were in trouble, but I was in trouble because the amount of money that the government has allowed me to entrust to save for my retirement, it's not as big as what it could have been if I had a defined benefit pension plan. So we're in the same kind of situation with our healthcare. We're pushing a lot of decisions to employees for healthcare. So we have retirees right now. They can be covered under a health plan under 65. Very infrequent. You see that now, but you see a lot of the employers who have retiree offerings over age 65 that have done away with them because of the FASB issues. We can employ this is a company in Ohio that had a closed group of under age 65 retirees for their health care. There's 460 eligible. There were 40 on the plan currently. And all it was a kind of a defined benefit plan. It was a defined benefit. They froze the benefit. The benefit was $125 or $130 a month, and then the retiree contributed whatever the excess was. So we looked at this thing, and the way that the financial, or let me rephrase that, the way that the employer charged the employees, the retirees, was not really equitable because a lot of the claims costs they were shifting to the active employees. So when we went in and calculated what the early retirees' costs were, it became unaffordable for the employees to continue. So what we did is we created a retirement health care, an HRA for retirees. And what we're doing is we're funneling that dollar amount through the HRA to these retirees, and they can go out to the exchange wherever they live. Sometimes they can qualify for subsidies based on their income. Sometimes they don't, but they can take that dollar amount and buy the coverage on the exchanges. So it's a different way of being able to provide a nice benefit to employees and not foregoing any subsidies that they may be eligible for. The AGRIP, the RAP plans. These are great. Everybody's familiar with the government subsidy. It was about $600 employers got, and it was great because it was tax-free, you didn't have to pay taxes on it. And then what the government did for the OP, what's that called, Tony? OPB? Yeah. They would only allow you to write off for that 1 year's cost. So if you created an AGWIP plan using a pharmacy benefit manager, the government would allow you to, instead of taking the calculation for the 1 year, you could take the calculation all the way out. Not only that, you didn't have to go through these onerous reporting things. And the subsidies were 40% higher. So any employer that has retirees on a pharmacy benefit plan should look at these AGWIP plans. And the WRAP programs now just kind of guarantee that the benefits for the retirees are the same as what they currently are. They see very little difference, but it's a way of, we're talking about a significant amount of money without really changing the dynamic. The skinny are the MEC plans. Now, I invite you to go on the web to Kaiser. Kaiser did a great write-up on these skinny MEC plans in July of 2013. And then there was a terrific article in the Wall Street Journal later on than that. I think it might have been in October. They're called skinny plans, MEC plans. And it's kind of interesting. You can't, you have to differentiate between minimal essential benefits and essential levels of coverage. In essence, to keep this real simple, what an employer can do is, to comply with the law, you have to offer a minimum level of benefits, minimum essential benefits to your active employees working more than 30 hours a week and their dependent children. This level of essential benefits is limited to wellness benefits. Milliman did an actuarial study on how much it costs for wellness benefits. It's about $50 a month per employee. So you could create a MEC plan or a skinny plan, comply with the Affordable Care Act, spend $50 a month in claims, so says Milliman, self-funded, because it has to be exempt from state regulation, and comply with the Affordable Care Act. The individuals would not have to pay the penalty. The only thing that you would be fined for, like somebody mentioned in an earlier presentation, if somebody goes to the exchange and is awarded a subsidy, if that person goes to the exchange and they're awarded a subsidy, there's a $3,000 fine. But it's not $3,000 for every employee. It's only $3,000 to people that go to the exchange. It's kind of a cool thing. I urge you to just Google it. Oh, here's some preventative care samples of some of the things that you have to do. Now you got to remember, we've got a federal plan here as opposed to a plan that's regulated by the state. So if the state of Utah says that you have to cover health plans, gyms, that's a different thing. This is a federal self-funded plan. Let's see what else we have here. Children, these are the things that you have to do for children. This is something that we wanted to put in about the mandates being deferred. Most employers think that, and they should think that the changes have to be made on your plan year, these new effective dates. They're not really on your plan year. They're effective January 1. So some of you who are July 1 plans are going to go through all this stuff, and then you're going to have to go through it again to make sure that you comply with the law. So there's a interesting thing that we're going to augment. We can post this on the FAQ thing once we do it, because it happened yesterday and I've been here, so we haven't been able to update it. It's on our blog. So I'm done. But I'm coming from a different direction. I'm not an insurance company. I'm not an employer. We just come up with ideas all the time. So thank you.